This is a presentation on graft choice in ACL reconstruction. Several options are available when selecting a graft for ACL reconstruction. These grafts vary by source, makeup, and how they are secured in the patient's knee. The goal of this presentation is to provide information on graft options that will enable patients to make an educated decision when discussing graft choice with their surgeon. There are two graft sources, autograft and allograft. Autograft is a graft of a tendon taken from the individual who is having the surgery. Most commonly, it is the hamstring tendon or patella tendon. Allograft is a graft harvested from a human cadaver. Commonly used tendons are patellar tendons, hamstring tendons, Achilles tendons, or ankle tendons. There are different autograft and allograft types. Autograft types include hamstring tendons, which are considered soft tissue, patella tendon, which is considered a bone plus the patella tendon plus bone, as well as the quadriceps tendon. Allografts can be posterior or anterior tibialis ankle tendons, hamstring tendons, patella tendons, as well as Achilles tendons with or without a bone block. The patella tendon is harvested from the patella during the surgery. It is also called a bone patella tendon bone or BTB graft because a bone block from the patella and the tibia remain attached on either end. Only the central third of the tendon is taken, leaving intact tendon medial and laterally, which is sewn up. Autograft hamstrings are harvested during surgery using the same incision used to make the tibial tunnel. Typically, the semitendinosus and gracilis tendons are taken to prepare the graft. Allograft options mirror those for autografts. There are bone patellar bone as well as soft tissue grafts. However, the harvesting process allows for complete tendons to be removed and larger bone blocks to be removed, as there is no concern for donor tissue regeneration or damage to the surrounding structures. If you compare graft sources, there are general benefits of autografts. There's no risk of disease transmission, and there's potentially a lower re-rupture rate than allograft in younger patients. One study in patients under 25 years of age cites a 5% re-rupture rate with an autograft versus a 9% with an allograft. The advantage of autograft diminishes in that study as the patient reaches age 40. Theoretically, graft remodeling is faster in an autograft. The graft acts as a scaffold which the body eventually replaces with new tissue. This happens in both allografts and autografts, but the process may be faster with native tissue. Quicker remodeling theoretically indicates the graft will reach maximum strength faster. There are also disadvantages to autografts. There's increased surgery time, there is pain, weakness, and stiffness at the graft harvest site, and there's a possible need for augmentation with an allograft. Sometimes the harvested autograft tissue is less than 8 millimeters in diameter, which is inadequate as a graft. In this situation, an allograft can be used to reinforce or hybridize the graft or replace the graft. There are also benefits of allografts. There's decreased pain and morbidity related to graft harvesting. A variety of graft sizes are available and can be selected before the surgery, and grafts are available with or without bone, which may be useful in a patient having a second or third ACL surgery, also known as revision ACL surgery. Some of the disadvantages of allografts include the potential for disease transmission, although the risk is extremely low, the increased time to remodel a graft. Theoretically, the graft may require more time than an autograft to complete remodeling, increasing the possibility of graft failure during the rehabilitation phase. However, this is not currently backed by clinical data. There's also the added cost to the insurer or patient of an allograft. You can also compare graft types, including the bone patella bone. One of the advantages is that the bone blocks on either end facilitate early bone-to-bone healing. There is rigid fixation at the bone-to-bone interface, and many consider it the gold standard for contact athletes at college or professional level or above. There are also many disadvantages. Anterior knee pain is common up to 1 year after the surgery and can persist beyond 1 year for an autograft BTB harvest. There is data to suggest that patellofemoral joint contact forces are changed and lead to earlier kneecap arthritis. There is also the potential for patella fractures in the postoperative period. Additionally, large tunnels are needed, which may typically affect any subsequent surgery. Metal screws are often used for BTB fixation, which may affect visibility of the knee with subsequent MRIs. There are many advantages to using a hamstring tendon autograft. It is simpler to harvest than a BTB graft. There is no need for additional incisions, and the tendon is harvested through the same incision used to make the tibial tunnel. There is less post-op pain compared to a patella tendon autograft. Some disadvantages are the potential for persistent hamstring weakness. However, strength typically returns to normal by 1 year. There is also the potential for hamstring to be too small or too short, which can only be determined after the tendons are harvested. No single graft has been shown to be superior across multiple studies. Age, activity level, and rehabilitation goals are carefully considered. Surgical technique, including tunnel placement and graft fixation method, is considered more critical to outcome than graft selection. Rehabilitation protocols also contribute to successful graft healing. In conclusion, there are several options for graft selection in ACL reconstruction, although no single graft is superior. Patients can discuss recovery goals with their surgeon to determine the most appropriate graft choice. Proper surgical technique and appropriate rehabilitation are critical to promote a successful outcome.